Welcome to HeartSpeak Consult Live, a webinar created by Baylor Scott & White Heart and Vascular Hospital, Dallas, Fort Worth, and Waxahachie. This is an opportunity designed for primary care providers seeking treatment options for patients who may be experiencing a cardiovascular concern. Today's program, There is Nothing Peripheral About Peripheral Artery Disease, is presented by Dr. Subhash Banerjee, Clinical Professor and Chief of Cardiovascular Research and Innovation, and Interventional Cardiologist on the medical staff of Baylor Scott & White Heart and Vascular Hospital, Dallas, Fort Worth, and Waxahachie. During this presentation, Dr. Banerjee will provide an overview of peripheral artery disease, including prevalence and risk factors, as well as review why early diagnosis is key for optimal outcomes. The course objectives are: establish multi-organ involvement of peripheral artery disease, outline clinical relevant screening of patients with suspected PAD, when to refer a potential medical therapy and revascularization options for patients with PAD. And now please welcome Dr. Subhash Banerjee.
Ladies and gentlemen, it is a great pleasure for me to be here on behalf of Scott & White and talk to you all about peripheral artery disease. Now, the first thing I want to get out of the box is that there is nothing peripheral about peripheral artery disease. And let me share how it connects to each one of us who are interested to know about heart and vascular conditions. So as you see, buildup of plaque in the blood vessels does not just happen in the heart. When it happens in the blood vessels of the heart, it is called coronary artery disease. When it happens in the blood vessels that feed the lower limbs or even upper limbs, it is called peripheral artery disease. And when it affects the blood vessels that feed the brain, it is called cerebrovascular disease. This slide signifies the buildup of plaque in the blood vessels of the lower extremities. And that is why this condition is termed as peripheral artery disease. However, it is part of a continuum of buildup of atherosclerotic plaque. That's what we call lipid-rich plaque buildup in the heart arteries and in the blood vessels of the limbs. And these conditions are intimately connected to each other. Now, peripheral artery disease is highly prevalent. Now, this map of the United States indicates age-adjusted mortality rates from peripheral artery disease-related conditions in the US. As you see, the lighter shades signify lower mortality rates, and the darker shades signify higher mortality rates. Peripheral artery disease is not just limited to men, contrary to common belief. After the age of 55 or 60, postmenopausal women are highly at risk of developing peripheral artery disease, very similar to that in men. And peripheral artery disease increases with age. This slide actually summarizes what I call the 2020 slide. Now, based on recent estimates, the number of individuals affected by peripheral artery disease could be as high as 20 million, although published literature reports it between 8.5 and 12 million in the United States. About $20 billion of our healthcare dollars are spent in caring for patients with peripheral artery disease. And if we do a screening test, which is called the ankle brachial index, about which I'm going to talk later in the presentation, about 20% of individuals above the age of 65 may have an abnormal test that would classify or diagnose a condition of peripheral artery disease in them. There are many ways this disease condition presents itself, but its extreme manifestation or extreme form of this disease is called critical limb ischemia, and that affects a fewer numbers of patients. However, it leads to a great number of hospital admissions and amputations. As I started off saying that because peripheral artery disease is because of blockages in the blood vessels that feed the limbs, especially the lower limbs, it is intimately connected, and individuals who develop peripheral artery disease or have peripheral artery disease are also at risk of developing cerebrovascular disease, that is stroke, or coronary artery disease that manifests with chest pain or with heart attacks. The natural history of this condition is worth recalling. As you will see on this slide, there are various ways patients with peripheral artery disease can present. The most common presentation is called intermittent claudication. These are individuals who have pain in their lower extremities with walking that is relieved at rest. However, an extreme form of severe manifestation of this disease is called critical limb-threatening ischemia. If you look at the 1-year outcomes of individuals who have developed critical limb-threatening ischemia, you will see that in 1 year, about a quarter of these such individuals are not alive. This condition is quite deadly, however, less frequent. The story with claudication is less ominous, and here on this slide, you will see the 5-year outcomes of individuals with intermittent claudication. Mortality rates over 5 years is between 15 and 30%. Many of these patients, about 20%, can develop heart attacks. But in terms of their limbs or legs or their ambulation, most individuals will remain stable, and only a very small minority of these patients can develop progressive disability and leading to amputations. So the summary is that intermittent claudication remains stable, and critical limb-threatening ischemia is highly progressive, deadly, and can lead to early amputations. Regarding the diagnosis, I think we often in our offices start by asking the question, does our patient have leg pain? And I am here to tell you that that is not the right question to ask, as majority of these individuals with peripheral artery disease conditions may be asymptomatic. Because this disease conditions develops insidiously, slowly over a long period of time, individuals may limit their abilities or adjust their lifestyles so that they are pain-free and may not recognize that they have developed peripheral artery disease. As you will see, typical leg pain with walking that is relieved at rest that I mentioned earlier was called intermittent claudication, affects only 15%. Atypical pain, tingling, and other symptoms can be present in about 33%, and critical limb-threatening ischemia with an ulcer or a sore on the foot that is non-healing in about 1 to 2% of individuals. So what is this test that I spoke about earlier, which is called ankle brachial index, that could be done to diagnose this? This is very simple, although there are specialized equipment to do this test. It is basically a ratio of the blood pressure at the level of the ankle over the highest blood pressure of the two arms. So if you take a 4-point blood pressure in an individual, you take the highest of the two arm blood pressures as the denominator and respective leg, ankle level blood pressures as the numerator. So hence you will come up with an ankle brachial index for each lower limb. As you see on the slide, the normal ankle brachial index is between 1 and 1.39. So the ankle brachial index is abnormal if it is below 1, say 0.9 or 0.99 or lower. It is abnormal if it is above 1.39 or 1.4 or above, which simply means that we are requiring a higher amount of pressure to compress the arteries of the leg due to development of extreme calcium deposits in those arteries that happens frequently in patients with kidney disease and diabetes. Now, who should be tested for ankle brachial index? First off the bat, I want to tell you that individuals who are very active, they have no symptoms, they have no heart or other vascular disease in any other territories, should not be screened if they're completely asymptomatic. But most individuals who are above the age of 65, who have risk factors for heart and vascular disease, who have diabetes or history of smoking, and those who have had plaque-related disorders, for example, minor stroke, major stroke, stent in the heart, bypasses, those patients have already demonstrated that the propensity to develop plaque in their arteries and cause hardening of the arteries, those individuals should appropriately be screened with an ankle brachial index. In the clinic, This is an important cheat sheet that I often use in my clinic. Now I have it memorized, but I urge, if one of my colleagues or primary care specialists are joining this call, is to use this simple cheat sheet to triage or screen individuals for peripheral artery disease. You see on this screen that the top part identifies the risk factors like high blood pressure, diabetes, high cholesterol, smoking, and kidney disease. The very bottom talks about limitations to exercise, bad nails, loss of hair, and in the middle part are all the symptom categories that could be related to peripheral artery disease. Epidemiologic studies in the US and around the world have indicated that African Americans and Black individuals are at a much higher risk of developing peripheral artery disease, very similar to those who have diabetes or have a history of smoking. Now, a word about smoking. There is no safe limit for smoking. It doesn't help to just lower down the amount of use of tobacco or cigarettes or tobacco products. One has to completely quit. There is no safe limit for tobacco. What can you do to reduce your risk of developing peripheral artery disease? It is obvious from the risk factors that managing your diabetes well, controlling your cholesterol, stopping use of tobacco-related products, a healthy lifestyle, periodic checks with your primary care, and for my colleagues who are on the call, taking off the socks and examining the feet of our patient is going to be critically important. And for additional questions, feel free to refer those patients with advanced conditions or diagnosed PAD if you need help to a specialist in your area. Now, talking about foot examination, it is not uncommon to find a non-healing sore or a wound or an ulcer at the foot examination. As I've already said, these individuals, if they have critical limb-threatening ischemia, their outcomes are extremely poor. They have a very high rate of amputation, and about, as I said, 25 to 20% of these individuals may not be alive in a year's time. So what to do after you have examined this patient? The first step is to perform an ankle brachial index, like I've said. Now, every patient with an ankle brachial index that is not in the normal range does not have to rush to a procedure or to an invasive test. If the individual is classified as having intermittent claudication without an ulcer, without critical limb-threatening ischemia, monitoring and managing them with medications and controlling their risk is the first step. If their ankle brachial index are in the normal range, however, their symptoms are suggestive of peripheral artery disease, then doing a walking ankle brachial index to induce the pain and lowering of the ABI, which we call an exercise ABI, is highly recommended. For those where there is hardening of the arteries and the ankle brachial index is in the higher than 1.4 range, doing a toe brachial index is also important to correctly classify them. Now, this is very different for those individuals who have critical limb ischemia, and those individuals should quickly be diagnosed with an imaging study. Sometimes it can be an angiogram, an invasive procedure, but a CT scan or MRA and an ultrasound could also be performed. Let me share a case example of a patient. You see on the screen that this individual has an ulcer in the foot. And I tell you, if I remember vividly, when this individual stood in front of me, I wasn't able to see the ulcer that is on the plantar surface, on the sole. And I had to do a comprehensive examination of his foot to actually see that there was a large ulcer on the plantar surface of his foot. You do see that his waveforms of his pulse volume recordings that we call and an ankle brachial index values are highly abnormal. His angiogram, because he was classified as having critical limb-threatening ischemia, we quickly proceeded to perform an angiogram of his leg, and you see this middle artery, which is called the peroneal artery, has got a very, very tight blockage. And the artery to the foot are quite diminished, and there is very little blood flow to the feet. Performing a simple angioplasty procedure, minimally invasive, restores the blood flow to the foot and leads to significant improvement in his symptoms, healing of his ulcer, and also restoration of blood flow to his foot, as documented on the right side of the slide by normal pressure waveform recordings and also normalized ABIs. I talked about the overlap of coronary artery disease and peripheral artery disease, but there are some important differences that I would also like to highlight. The first is that patients with peripheral artery disease have a higher risk for clot formation. Second is that arteries, especially in the heart, for patients with peripheral artery disease have much bulkier plaque, and their vessels don't dilate or expand as much as those without peripheral artery disease. On the right side is an important information. If we control bad cholesterol levels or fail to do so, the increase in plaque formation is significantly greater in patients with peripheral artery disease. That means they are more resistant to plaque regression and can even show progression with suboptimal treatments. Which brings us to the next question, that are there effective ways to lower this risk? I'm sharing a study data of a very potent cholesterol-lowering medication which is called PCSK9 inhibitor. It is an injectable form of cholesterol lowering, and this study shows that individuals who have coronary artery disease and peripheral artery disease, that means more diffuse plaque formation in the body, those individuals show a profound effect with this cholesterol lowering treatment, which is highly efficacious with an increasing number of severity of vascular conditions. We've also studied and more press about novel risk factors. Now I say it is novel not because it was not known, it is because new therapies to address this are becoming more prevalent. And that risk is called lipoprotein A. It's a form of bad cholesterol that is completely inherited. You cannot reduce it or lower it with activity, diet, and with most medications like statin therapies. However, some injectable therapies that are available and some that are about to be approved by the US FDA might be very, very effective in lowering this condition. However, it is highly associated with development of vascular disease, including PAD, and with clot formations. An important arsenal in our treatment of peripheral artery disease is the use of blood thinners. There are important studies that have indicated that low dose of rivaroxaban can be efficacious in reducing the risk of future events in patients with PAD, and especially with polyvascular disease. There are various conditions on the top of this slide as shown which identify at-risk individuals who could benefit. But the problem is, as you would have guessed, that giving a blood thinner is not without risk. And individuals identified on the bottom of the screen are those who can be at a higher risk of bleeding. So referring to a specialist to make this determination might be the best option. To summarize, individuals with heart and vascular conditions, that means individuals who have got diffuse plaque buildup in the body that affects their heart, their other areas like the brain or the legs with PAD, should be treated very aggressively with cholesterol lowering, identifying novel risk factors like I mentioned, lipoprotein A, lowering the bad cholesterol or LDL cholesterol to less than 70 milligrams per deciliter, and in some cases even below 55. And of course, considering medical therapy and optimization with rivaroxaban low dose. Now this is above and beyond the lifestyle changes that we talked about, controlling your cholesterol, body weight, activity, foot examination, and most importantly, quitting all forms of tobacco. When I started my career, this slide was pretty empty. Now it is a very well populated slide with multiple treatment options. If you notice, the word MALE stands for major adverse limb events. In most patients with critical or acute limb ischemia, sending them to restoration of blood flow with either minimally invasive procedures called endovascular or surgical techniques is the most appropriate way. However, for those with lifestyle limiting conditions like intermittent claudication, exercise therapy, whether it is supervised at a hospital or in an office or self-monitored, along with risk factor modifications and the various medications shown here, are extremely efficacious and should be part of regular treatment of these patients. A word about restoration of blood flow. It is very important to do so promptly for individuals with critical limb-threatening ischemia. However, in individuals with intermittent claudication, restoration of blood flow through minimally invasive or surgical procedures should be employed only if medical therapies are unsuccessful or suboptimal in controlling the symptoms, or the symptoms are progressive or seriously lifestyle limiting. It is not appropriate to do a prophylactic intervention in a patient with claudication to prevent the progression of their claudication to critical limb-threatening ischemia, as that happens quite infrequently. There is a lot of debate about which therapies are better, and this is one of the recent studies published and performed by the National Institute of Health, which shows that for patients with critical limb-threatening ischemia, surgical revascularization actually was better than minimally invasive therapies. However, the bigger picture is, as you see on the slide, that 33% of patients in the surgical arm and 37% approximately in the minimally invasive arm died. So the big picture is that surgeons and interventional cardiologists need to collaborate along with other healthcare providers to quickly and expeditiously identify at-risk individuals and use appropriate medical therapies along with restoration of blood flow as means of improving the life of these patients and saving their limbs. The distinction between an intermittent claudication and a critical limb-threatening ischemia persists even when they undergo minimally invasive procedures. As you see in the dark blue, individuals with critical limb-threatening ischemia have higher post-procedural death, risk of amputation, need for repeat procedures, or even heart-related conditions or heart attacks. So how can we find individuals who could be at risk but yet not in our offices? Now, this is a great study which was one of the late-breaking studies recently published that indicates that electronic medical record-based screening for healthcare providers can help identify many at-risk individuals. I, at Baylor Scott & White, along with my colleagues, lead a Medicare-approved qualified clinical data registry, which is now called a CMS-approved QCDR National Registry for driving quality of care and measuring outcomes of patients with peripheral artery disease who are undergoing minimally invasive treatment for PAD. In conclusion, I would like to leave you with these final messages. As I've indicated, peripheral artery disease is highly prevalent, it is multi-system, and is one condition in a spectrum of heart and vascular conditions that are identified as CAD, CVD, and PAD. So there is nothing peripheral about peripheral artery disease. Second is that carefully identifying our patients in clinic, asking them appropriate questions, performing a good physical exam, including with a foot exam and an ankle brachial index, can diagnose most of these patients. And of course, appropriate medical therapy along with early referral to specialized care can be both life and limb-saving for our patients. I hope you enjoyed this presentation. Thank you so much for having me today.